Good afternoon, everyone. My name is Olivia Marquez, and I am a team member with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series, and today we will be discussing daily oral iron supplementation during pregnancy. What's the evidence? So just before we get started, I'll remind our audience that we will be posting polling questions throughout the session. Your participation in the polling questions is voluntary. Your names will not be recorded, and your participation in the polling questions will be accepted as an indication of your consent to participate. So we hope that the polling questions will enable your engagement and stimulate discussion throughout the session. So I'll leave this consent slide up here for just a moment for you to review. Okay, so just to let everyone know that after today, the PowerPoint presentation will be made available on Health Evidence on our YouTube and SlideShare account page within the next week. So the link to our SlideShare account and our YouTube page will be posted in the chat section on WebEx. So today we will be talking about this systematic review, and there's a link to the review, to the Health Evidence Summary page for this review. That will be posted in the chat section, as well as a link to the full text review on the Cochrane page, as well as a plain text summary. So those links, again, will be in the chat section, so you can pull up the review if you like to follow along throughout the presentation today. So we'll be starting with our first polling question today, which is, what sector are you from? Do you work as a public health practitioner? Are you a health practitioner? Do you work in education, research, government, as a policy analyst, or other? So once you have selected your response, please click Submit at the bottom. And thank you, everyone, for your participation. We're seeing that we have quite a few public health practitioners joining us today, so that's great, and a few other health practitioners. So thank you, everyone, for your responses. Just a few housekeeping issues. So please use the Q&A and chat in the WebEx to post your questions and comments. We ask that you please send your questions or comments to all of the panelists and not just to the host. If you do, it's not a problem. We will still see the post, but it does help as other attendees may have similar questions that you have. So towards the end of the session, we'll have a question and answer period, and I will be able to read your questions aloud to our presenter to respond. You don't need to wait until the end of the session to post your questions. You can do so as we're going through. So the best connection we recommend for today is that you connect using a wired internet connection as opposed to wireless. And if you do have any connection issues, you can contact the 24/7 WebEx helpline, which is on the slide, and will also be posted in the chat section. So for your audio today, we recommend you listen through your speakers, and you can click Communicate on the top tab in WebEx, and then click Audio Connection. So we have our second polling question here, which is, how many people are watching today's session with you? Is it just yourself? Are you with 2 or 3 others, 4 or 5, 5 to 10, or over 10? So again, thank you everyone for your participation. We're seeing that the majority, almost 75%, are joining by themselves, and we have another small portion who are with 2 to 3 other people. So thank you very much for your responses. We have a special thanks to our Health Evidence team who helps to support and bring you the session today. There's a large team of us who works to keep health evidence current and maintained, as well as searching for reviews to feature in our monthly webinar series. It's definitely a team effort. So for those of you who may not be familiar with health evidence, we launched in 2005, and it's a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors per year access to over 4,400 quality-rated systematic reviews. We provide links to full text, review summaries, and also provide webinars like the one you're attending today. One of the main goals of health evidence, in addition to making evidence on the effectiveness of public health interventions more accessible, is to make it easier for professionals to use evidence in decision-making. So the value added in this is that we save you time in many ways. We search for you to find newly published literature related to public health. So we are also open about our screening process, and we provide relevant and current evidence that's as up-to-date as possible. We use a transparent process whereby we're open about how we actually search, screen, and appraise all reviews in our registry. And you can actually see the double screen of quality appraisals for each review on health evidence. We provide a variety of supports and tools to facilitate evidence-informed decision-making on our website. And we've been told by users over the years that they find it very easy to use. So I'll post up a model for evidence-informed decision-making in public health. And this consists of the 5 components you see on the diagram. So traditionally, public health practitioners and decision makers do consider evidence about community health issues and local context, existing resources, and community and political climate in making decisions about programs and policies. However, it's become apparent that considering evidence about research may be more challenging. As such, the Health Evidence webinar series is designed to identify research evidence relevant to public health decisions. So the evidence-informed public health wheel that you see here illustrates the steps that are involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. So there are 7 steps in the EIPH wheel. And today we will hear about how our presenter, Luz Maria, has worked through the first 4 steps in this process in order to help with the decision makers with the remainder of the 7 steps. So we have our next polling question here, which is, have you ever heard or are you familiar with the PICOS term? So yes or no. And thank you for your responses. So we have quite a few people are saying yes, and it's actually about half and half for people who are familiar and unfamiliar with the PICOS term. So thank you for your responses. So PICOS is a way to structure your quantitative research questions in a defined set of evidence-informed decision-making. So this involves defining the population or situation, the intervention or exposure, a comparison group if there is, outcomes you're looking for, and the setting. So this helps you to structure your research question and then search for research within that realm. So another polling question of how often do you use systematic reviews to inform a program or service? Always, often, sometimes, never, or you may not be familiar with what a systematic review is, which is fine, and hopefully today we'll be giving you some insight into systematic reviews and the process that's involved. So we have quite a few responses. We see that few people, almost 36%, often use systematic reviews, a few sometimes, and we do have a few people who never or aren't sure. So hopefully we'll review and enlighten you on that process today. So today it is my pleasure to welcome Dr. Luz Maria De-Regil, who is the Director of Research and Evaluation at the Micronutrient Initiative in Ottawa. So before we get started, we'll just ask your opinion on the outcomes that we'll be discussing today. So daily oral iron supplementation improves health outcomes for pregnant women. So before you're hearing the findings, do you strongly agree? Agree? Are you neutral or disagree? So thank you for your responses. We see quite a few people are either strongly agree or agree. We have about 8% who are neutral on the topic, and no one has yet disagreed or strongly disagreed. So with that, I'd like to pass the presentation over to Dr. Luz Maria De-Regil, and we are very pleased to have you present your findings for us today. Thank you for joining us.
Oh, thank you so much for the invitation. I tend to speak very fast, so please let me know if something is not clear or I'm rushing any of the information that I'm presenting here. As a background, I would like to say that I'm not the lead author of this systematic review. It's Dr. Juan Pablo Peña-Rosas. He works in the World Health Organization. And I personally think that this systematic review is a very nice case of how evidence is built throughout the years. He started with this systematic review in 2001, and the review has gone through 4 updates, and we are working on the 5th one because the amount of evidence that is coming after iron supplementation has become more known among the practitioners, more evidence is coming, and also more evidence of good quality. So Juan Pablo, I think that is an example of commitment to the Cochrane collaboration. And I joined the systematic review for the 3rd update. And of course, I'm a strong believer and supporter of the Cochrane collaboration and the spirit of how you can summarize the evidence in an unbiased way. And especially I welcome all these efforts in terms of translating the systematic reviews. These systematic reviews are around 600 pages long. So having the opportunity of having these presentations and translated them into something that can be useful for the general practice, both at clinical level and at community level, is very, very useful. So that is a part of the background. Also, I would like to say that this systematic review has been very important in terms of policy making. The previous version and this version have been used to update WHO guidelines. And you can see that in the conflicts of interest or in the acknowledgement section in the systematic review. And after that, many countries have updated the policies as per this systematic review. To my knowledge, at least 20 countries have updated the policies. And now, this version has been used to update the guidelines on iron and folic acid supplementation as part of the antenatal care that WHO is going to release later in the year. Just to get started, well, many of you know what a PICO question is, but for those, just as a reminder, PICO stands for population, intervention, control, and outcomes, control or comparison and outcomes. In this case, the population that we wanted to study was pregnant women of any gestational age and parity. The intervention that we were looking at was daily iron use of supplements, either alone or in conjunction with folic acid or with other vitamins and minerals. The reason for having this is because we wanted to isolate the effect of iron, but iron supplementation, and I will go into that later, has been recommended as an intervention in antenatal care since the 60s, and all the references are around iron. But in around 2000, the recommendation was updated and folic acid was included. And in many countries, particularly high-income countries, iron is given along with other multiple micronutrients. So we wanted to isolate the effect of first iron and second folic acid. So you see here the comparison is same supplements without iron, no treatment or placebo. The outcomes, maternal outcomes, were maternal anemia, iron deficiency, and iron deficiency anemia at term. And infant outcomes were lowered weight, premature birth, hemoglobin concentrations in the first 6 months. And it was interesting. The question that was posted was in terms of maternal and outcomes. However, most of the interventions in pregnancy are related to the birth outcomes. And in many of the cases, the decision-making is driven more by the outcomes on in the infant than those in the mothers. So just as we wanted to look at both. Iron deficiency anemia, for those who are not familiar, and this is the problem that we were trying to solve, is the most important nutritional deficiency in the world. Anemia is the information that we have. It affects around 32 million pregnant women every year, which is about 1 out of 2 pregnancies in the world. It affects mostly women living in developing countries or low and middle income countries, and it starts as a result of many causes. Poor diet with inabsorbable iron. That means that diets that have a lot of cereals in and poor variety are at risk of having a low iron, absorbable iron. Usually those diets are insufficient also in iron, and that means that women cannot fulfill their needs. And in pregnancy, the amount of blood increases, so women have increased iron requirements. Other causes, it's not infrequent that in low and middle income countries, there are also a high prevalence of parasitic infections like hookworms that increase blood losses and thus increase the needs of iron and other blood losses. Just as a reminder, and to give you the overall context, anemia also affects around 500 million women of reproductive age. That means women of between 10 or 15 years and 49 years of age. So if we think about that, many women are entering pregnancy with anemia. And in those cases, in addition to the diet and the parasitic losses, menstruation is a trigger of anemia if there is no adequate iron intake. This is a global landscape of anemia. You can go to the WHO website and you can see exactly what I'm showing, that in low and middle income countries, particularly in sub-Saharan Africa and Southeast Asia, anemia is highly prevalent. That means that it's a severe public health problem. That means that it affects more than 40% of the population. And in some cases, you can see in the map, the darker countries are 60% of the pregnant women have anemia. Sorry. Iron supplementation, as I was mentioning, has been used extensively in most of low and middle income countries. And the used term is a very broad interpretation of the term. There are almost all countries have policies for iron and folic acid supplementation, but the intervention has not been fully implemented. And that's why the prevalence of anemia remains high among women of reproductive age. As I mentioned before, inclusion of folic acid is also recommended, and is recommended not because of neural tooth defects. At this time in pregnancy, it's very late to prevent any neural tooth defects, but folic acid requirements are also increased in pregnancy due to the rapid dividing cells in the fetus and increased urinary losses. Iron supplementation has been used in a variety of doses and frequencies. And currently, the recommendation that resulted, as I mentioned, from the previous systematic review, is that daily iron and folic acid supplementation can be given in a dose of between 30 and 60 milligrams of elemental iron and 0.4 milligrams of folic acid, and it should start as soon as possible. That guideline is available in the WHO website. Since there is a range, also WHO provides guidance in terms of anemia populations with a prevalence of 40% or higher should receive a daily dose of 60 milligrams of elemental iron and is preferred over the lower dose. The lower dose may also have an effect, but a higher dose may be more effective at population level. And this is a public health intervention and where screening is not always possible. If screening is possible and anemia is diagnosed, then there is another recommendation that it should be given. Women should receive 120 milligrams of elemental iron per day until anemia disappears. And as a parenthesis, I would like to make the point that we are talking about daily supplementation, because there is another type of intervention also for pregnant women with a low risk of having anemia, that is intermittent iron and folic acid supplementation. So there is a sibling to this systematic review that addresses intermittent iron and folic acid supplementation. Intermittent means that women receive iron supplementation once or twice a week or 3 times a week on non-consecutive days. Why is this review important? I think that I have made my case in the initial slides. But it was important because, as I said, it has been recommended since 1968, and there was no systematic, before this review, there was no systematic assessment of the benefits that iron supplementation could have on maternal and infant health. Also, iron anemia tends to be highly prevalent in areas where malaria is endemic, and there were some suggestions that iron supplementation might increase the infection in some settings. So we wanted to prove that this intervention was safe in malaria endemic areas. And as I mentioned, these results update the previous systematic review. The objective was to assess the effects, and we use effects for those who are not familiar because with the systematic reviews, because we wanted to prove the benefit and safety of iron intervention, so positive and negative effects of daily iron and folic acid, daily oral iron supplementation by pregnant women, either alone or in conjunction with folic acid or with other vitamins and minerals as a public health intervention in antenatal care. I'm not going to go through the PICO question again, but I will say that this review includes only randomized studies, cluster randomized and quasi-randomized trials. There are other studies assessing using different designs for iron supplementation. The Cochrane pregnancy group only allows the studies that are randomized and cluster randomized studies or quasi-randomized trials. Other groups within the Cochrane collaboration allow for other designs. The types of participants were pregnant women of any gestational age and parity in living in any setting. We excluded studies that were targeting women with particular conditions such as HIV, for example. There were many comparisons in the review, as the purpose was isolated first, the fact of receiving any iron versus not receiving iron, and then we went through different comparisons to assess whether the iron and folic acid as a pair would have an effect, since that is a recommendation and the standard of care, and whether the addition of multiple macronutrients, there are most of you, if you are living in Canada or in the U.S., know that most of the supplements that are available in the market contain also other vitamins and minerals. So we wanted to assess whether those vitamins and minerals had an additional benefit over iron and folic acid for the outcomes that we were exploring. You will have the presentation, so as you can see, there are multiple outcomes. The primary outcomes for the infant were lower weight, birth weight, preterm birth, neonatal death, and congenital anomalies. For maternal outcomes, we wanted maternal anemia at term, and we defined it as not exactly at birth, because it's very difficult to measure anemia at birth, but 36 weeks and higher. In many cases, it's easy or feasible to collect anemia measurements or hemoglobin measurements at week 36 of pregnancy, and that is considered as an indication of anemia at term. Maternal iron deficiency at term, maternal iron deficiency anemia at term, maternal death, as I said, and side effects as a safety measure, severe anemia at any time during the second or third trimester. Anemia in many cases, severe anemia particularly, is associated with a higher mortality for both the baby and the mother. So that was an important measurement and clinical outcome. Clinical malaria and infection during pregnancy. And the list of secondary outcomes is here. You will have access to the systematic review. The Cochrane Pregnancy and Childbirth Group assists the reviewers with the search, and the search strategy is publicly available, and they search in these databases. We also contact, as part of the exercise that we do, as part of this, we contact relevant institutions that we know that are implementing iron and folic acid interventions, such as the Centers of Control for Disease and Prevention of the United States, the Global Alliance for Improved Nutrition, the Micronutrient Initiative, UNICEF, the Maternal and Health Unit, to see whether they have reports that have not been published that can provide additional information. So if you look at the flow diagram, we have almost 400 records identified through the database searching, and 4 additional records through other sources. Those are the reports that are coming from other sources. At the end, this is systematic review after including several studies, including and excluding trials. We have 44 studies that contribute to the quantitative analysis. Please note that we have 61 studies that are included in the qualitative synthesis. That means that we are including, the scope is you include trials that are looking at your intervention in your population, but it's not outcome driven. In the difference in those trials, the difference between 61 and 44 is that we had 17 studies that did not contribute data to the analysis because they were not looking at the outcomes of interest. Still, we decided to describe them, assess them, because they might open the opportunity to other research questions or to other people that are looking at other outcomes different than ours. I failed to mention that the selection of outcomes was not the selection or our choose as our option as a review team. The PICO question was scoped by a group of 20 experts or more with different geographic representation from WHO regions, which there are 6 WHO regions, 3 members from each region, plus an additional input from experts globally. So as a review team in this case, we didn't have a particular interest on any of the outcomes. We just wanted to respond to a question that was relevant in terms of policy making. That's why anemia ended as a first primary outcome, because that is what is driving the investment at country level. If we were researchers, particularly, we might be at some point. Our interest could have been the response of iron supplementation, the effect of iron supplementation on a particular indicator. In this case, we were interested in those outcomes that make sense in terms of policy making. There is a reasonable variety in terms of the trials. The first trials were done mostly in Europe and America, but now we are having more information from Africa, Asia, Australia, and we expect that in the next years we are going to have more geographic representation. We assess the risk of bias using the Cochrane criteria that assess how the sequence generation, allocation concealment, blinding of participants and personnel, blinding of outcome assessment, incomplete outcome data, and other types of bias. And everything is noted We really made a big effort, a huge effort in contacting authors. All the information is available in the systematic review. Juan Pablo is very keen to describe everything. And we have papers, and you can see here an example, that are as old as 1967. It's interesting because when you analyze an intervention that has been around for such a long time, you can see how the reporting has improved. So some outcomes, and let me go back here, some of the issues that random sequence generation was not very frequent. And authors did not used to report that in the past, as they are used to do that now. The consort criteria has helped to the reporting. So there is always a risk that the trial is of good quality, but the reporting is of bad quality. And we faced that, and we observed that in the trials that were conducted in the 90s, 80s, and in some cases, and we were able to contact a lot of authors. There is a very nice case, for example, of one of the authors, that this is a nice anecdote, that she said Juan Pablo wrote to her, and she was living in a nursery home. And she said, well, you are lucky because I'm alive. Juan Pablo, the main author, wrote to her asking for the data, and we were able to get her thesis. So not only a full description of the trial, but the data set, because in the 60s, they used to put the data set as an attachment to the thesis. And that information was shared with the Cochrane pregnancy group, and that is what built the central database also for randomized clinical trials. We attempted to contact authors through Facebook, and we received responses like, oh, this trial is sold, that I don't even remember it. It was when I was in my internship. Or in many cases, very positive responses saying, yes, here is the data. I don't have time to analyze it, but please go ahead, and if you can analyze it, it's more than welcome. And that is particularly important because we needed to do some assessments and adjustments, for example, for managing the data, cluster assessment, cluster adjustment to adjust for the intra-cluster correlation. So through contacting all the authors, the quality of the reporting improves, and we feel more confident about our assessment. The overall quality of evidence of the trials, as you can see, we have most of the trials are blinded. And I would say, just looking at this slide, that the trials are of mixed quality, some of them of very high quality and some of them with very low quality. Still, all of them are included. And the level of reporting, and as you can see, the low risk of bias is in random sequence generation, allocation, blinding, very similar across the studies. Well, this is a very detailed description of how the trials were assessed. I'm not sure if it's very useful, but you can see that in the main categories, we deem that a high-quality trial is one that has a proper description of the randomization method, a proper description of how the intervention was allocated and secured, and blinding, or a few losses to follow up. As you can see, in most of the cases, the blinding was the main advantage of the trials, and the losses to follow up was the second, probably the second best characteristic of the studies. For those who are not familiar with the GRADE methodology, it's a methodology that started probably 8 to 9 years ago to assess the overall quality of the evidence. If you look at this trial, this slide, it's very difficult to say how is the quality of the evidence. I could say here, and actually I did it, or even the previous slide, I said the overall quality of the evidence is mixed, or I don't feel that confident because I would like to see more green than a yellow or red. What GRADE does is it gets rid of this type of comments that is similar to the one that I made, and says, well, how is the quality per outcome? Is there any way that we can talk about outcomes rather than just trials? where the quality of the trial is just one of the components. And the reason for this is that primary outcomes tend to be better reported than some secondary outcomes. For example, side effects, the quality of the evidence for side effects is much less than for the primary outcomes. And if we just think in terms of studies, we are missing important pieces of information. And also, because of the nature of the systematic reviews, in some trials, the primary outcome is, in most of the trials, the primary outcome changes. We are deeming that we are considering that anemia in this case is a primary outcome, but in many of the outcomes, in many of the trials that we included, probably it was a secondary outcome. So that affected the quality of the measurements, the losses to follow up for that particular outcome, or how rigorous was the collection of data, or even the blinding of the personnel that assessed the measurement. So grade methodology attempts to describe the evidence, the quality of the evidence per outcome. And there are several categories for that. Moderate, low, low, moderate, very low, or high, and basically reflects the level of confidence that the reader or any policymaker may have on the evidence that is there. And the quality of the study or the quality of the assessment depends, as I mentioned, on the quality of the study, but also on how inconsistent are the findings, if we are gathering information from other populations, or how imprecise is the estimate. And after that, and the other important part is that all the judgments are transparent. In this case, I did a grade assessment. I also belong to the grade working group. And Seris Dowswell from the Cochrane pregnancy group was the other person that did it with me. So we developed a table, and as if we're doing the systematic review, we assess in a separate way the outcomes, and we put our after discussion, we came up with our assessment. And in maternal anemia, for example, you can see a term for me, which is defined as 37 weeks of gestation or more, that the quality of evidence is moderate. If we see maternal anemia near term, which I mentioned is week 36, we may have a different amount, a different number of trials, for example, because it's more feasible to measure anemia at week 36 than at week 37. So our judgments are also affected by the number of trials. And for example, you can see here that for maternal anemia, only 3 trials are contributing to the data. And if you recall, I mentioned before that we have 44 trials that reported that contributed data to the systematic review. So that reinforces the point that not all the trials report on all the outcomes that we are assessing. So it's important to look at this table to make the appropriate judgments on addressing carefully all the information that is summarized in the systematic reviews. The main results of the review are that anemia, that iron supplementation actually works to reduce anemia at term by 70%. If you think about an intervention that can reduce a problem 70%, there are very few interventions that have such a strong effect. But if you look at that, the number of trials and the number of women, you can deduce that the trials in general have a small size, and very likely are not very consistent. That's why the quality of the evidence for this particular outcome was low quality. Also, iron supplementation works for reducing iron deficiency anemia at term by more or less the same amount, 67%. 6 trials, around 1,000 women. It also reduces iron deficiency at term by 57%. So basically, if women are anemic or iron deficient, anemia is a good iron supplementation is a good intervention for them. We had multiple subgroups, and I did not mention them here, but basically, we did not find very clear significant differences between groups, subgroups. The only the only thing that may have an effect is that we were very interested was malaria, and we saw that there was no difference in the outcomes for malaria areas, and for maternal mortality, there were no difference in any of the outcomes, or not even in side effects. So these are the overall estimates. You can see that for some outcomes that are assessed in the safety of this intervention, like side effects, the confidence intervals are wide, so the confidence on our judgments or the quality of evidence is low. Also, maternal mortality is low, and that is related to the fact that these are randomized studies, and where women are at risk, sometimes they are excluded from the trials, and they are receiving the proper care, which is what is ethically correct. Also, for severe anemia, if you look at the confidence interval, I'm looking at the second bullet point, you will see that the confidence interval is very, very broad. So we have low quality of evidence, and this intervention works to prevent severe anemia. The only thing is many studies exclude at the very beginning. It's an exclusion criteria for the studies. So we don't have because of the nature of the individual trials, it's very difficult to assess the effect of some severe anemia. An important finding of this review, from the previous version of this review, is that there is a dose response in terms of iron. So if you give more iron to women, let's say 60 milligrams versus 30 milligrams, women tend to have higher iron stores if they receive 60 milligrams. Pregnancy is a period where women have a rapid absorption of iron. But also, in terms of physiology, you don't want that anyone has very high concentrations of iron or hemoglobin, because that can be associated also with negative side effects. So what we observe is that women that have higher concentrations of anemia term and receive iron doses were also at higher risk of having concentrations greater of hemoglobin concentrations greater than 130 grams per liter. The clinical significance of that is still to be explored further, but there are indications that it's not desirable to go beyond those levels in terms of hemoglobin. Of course, this is at sea level. In countries like in Mexico, that value is around 145 grams per liter. In terms of infant outcomes, there is an indication that iron supplementation reduces the risk of having babies with low birth weight. As you can see, the reporting is the number of women that are contributing data is much more bigger than for anemia, for example, 17,000 women. The quality of the evidence is low because it reflects a time trend, it reflects the variety of settings. And if you can see here, the confidence interval goes from 0.69 to 1.03. In the previous systematic review, which have less trials, the confidence interval was, the estimate was similar, the point estimate was similar, but the confidence interval was borderline between 0.99. So that reflects exactly what we are mentioning here, the low quality evidence. We reflect that a big trial or a large trial can affect importantly how confident we are in the results. And if we pay so much attention to the statistics, particularly meta-analysis, when you are using random models, you need to be very careful with the interpretation of borderline values. Consistently, all trials show an effect on lower weight. The only difference is that the magnitude of the effect. It also has an effect on, or it seems to have an effect on preterm delivery, of a reduction of 7%. And as of course it's related to the low birth weight issue, it seems that iron supplementation improves the weight of the babies at birth. Again, there were no clear differences between groups. And for the neonatal death, we did not find an effect of iron supplementation on neonatal death, neither on the neonatal death nor in congenital anomalies. We found no evidence that iron supplementation increases placental malaria, but I must say that this has been poorly explored in general. Conclusions. Women consuming daily iron supplementation have lower risk of anemia at term and preterm throughout pregnancy, higher hemoglobin concentration at term and at 6 weeks postpartum, and especially if they receive high doses of iron, they may be at risk of higher concentrations of hemoglobin. In terms of infants, there is a borderline lower risk of delivering lower weight babies, borderline lower risk of giving birth to infants less than 36 weeks gestation, and very similar with a very preterm delivery, which is less than 34 weeks gestation. Well, this is the overall summary. In terms of several of you, basically, they responded correctly. Daily iron and supplementation improves health outcomes for pregnant women. If we consider anemia as a health outcome, yes, iron supplementation works for women. In terms of other meaningful outcomes, it's always a question mark, and it may also have an effect on birth outcomes such as low birth weight and preterm delivery.
So, thank you very much, Luz Maria. That was a great presentation and overview of findings from your review. So we'll get into, before we get into the question and answer of the session, I'll open up a polling question. Your opinions have changed from the start of the session to now. Do daily oral iron supplementation improve health outcomes for pregnant women? So thank you for your responses. We have a few people who are still strongly agree, and about 6% who are neutral, and one person who has now said disagree. So it'd be interesting to hear their questions or comments about that polling question. So we have our last polling question today of, do you agree with the findings of this review? And again, if you strongly agree, are neutral, or disagree. So then we have most people are agree and neutral on their responses. A few strongly agree, and again, it'd be interesting to hear if anyone disagreed with the findings, what their questions or comments were. So I invite everyone to post questions or comments in the Q&A or chat section. And again, you can post your questions or comments to all participants instead of just to the host. So Luz Maria, we have a few questions that were posted through the presentation already. And Nadia had asked a question at the start, was that many of the pregnant population finds that taking iron supplementation causes GI distress or constipation. So they don't end up taking the needed iron supplement. So do you have any suggestions for these clients?
Yeah, that's absolutely correct, and one of the reasons for low compliance. That's why we wanted to explore lower doses of iron. It depends on the dose of iron and the frequency of taking the supplement, and I would say also on the time of the day. So, for example, 30 milligrams of iron has shown to be effective in preventing anemia and with lower side effects. I didn't show the effect of subgroup analysis in terms of side effects, but it's very frequent that women with 30 milligrams of iron do not express those concerns. 60 milligrams of iron, yeah, it's very frequent. Also black stools. constipation. And I would say that in most of the countries, because they have this high prevalence of anemia, are recommending that 60 milligrams of iron because it gives the best response in terms of anemia. So that's why it takes me to the second part, the timing of the day. When you explain women the benefits of improving iron status, secondary benefits are, for example, a better capacity to work. And when you are severely malnourished, that is an important thing, better oxygenation in terms of, because your hemoglobin levels are higher. If women understand the benefits of this intervention for her and her babies, are more likely to be compliant. And also at night, it's taking the time to explore with them whether it's better at night or early in the morning. For most of the women, taking the supplement at night is not as bad. And I guess that the other important messaging is if you miss one dose, take the second dose. Don't double the dose because no one wants to take more side effects. But take as much as iron doses as possible because each dose will have a positive effect, an additive effect. And when you communicate that, for those who are not familiar with the Micronutrient Initiative, we're one of the largest organizations working in developing countries in low and middle income countries to deliver iron and folic acid supplementation. And we have invested a lot in terms of behavioral communication interventions and also on improved interpersonal counseling. And we have seen that those investments pay off in terms of the compliance and adherence to the intervention. So every year we reach the right dose in terms of iron, amount of supplements that can be taken throughout pregnancy, although the recommendations say as short as possible. In low and middle income countries, women do not come to antenatal care as early as we would like. So there is an agreement in the international community that native supplements is a minimum appropriate dose. And with this counseling, with these improved materials for communicating the benefits of iron supplementation, we have seen that at least every year we are able to reach 2 million women in the right way, so they take 90 supplements or more.
Thank you very much for your response. That was very great.
Just let me complement this. I'm not sure about the geographic profile of the audience, but in Canada and the U.S., the dose of the supplements and the national policy, as far as I recall, is 30 milligrams per day. That dose, in the U.S., is even, I think, for 27. That means that the side effects, according to the Institute of Medicine of the U.S., appear when you have a daily dose of 45 milligrams of iron. So in countries like Canada or the U.S., the daily dose is lower than any side effect. It's far from the doses that are associated with side effects.
That's great. Thank you. So we have one question, or our next question from Becky, who's asking us to go back to the grade table. Is here. And if you could explain, for side effects throughout the intervention period, how would you interpret RR of 44.32 with such a wide confidence interval? Then how would you apply the moderate quality assessment to this interpretation?
No, you are absolutely right. I think that assessment is incorrect, and now I'm wondering what happened there, to be honest. What it reports is like, first, there is the wide confidence interval the wide confidence interval reflects several things. One is the poor reporting. You see that only one trial is reported in that period. But the other important piece is that any side effects can be the result of pulling. In this case, it can be the result of pulling several side effects, and then you say any, or it can be there is no good definition for side effects. But there is consistent international agreement on the positive effects. But for example, in this case, gastrointestinal discomfort, was mentioned in the previous question. What does that mean? Are we talking about it's just a perception? Is that a reporting? Is that I don't know, like in a scale 1 to 10, I have 7 of discomfort? It is very difficult to measure side effects, and there is no international agreement on what we mean by that. So I would say that confidence interval reflects several things related to side effects. And I would say that the reporting, in this case, the assessment, should be downgraded to low quality evidence or even very low quality of evidence. So a good point, Becky, is going to be in the update. We are going to address it.
That's great. Thank you for your comment on that. We have another question from Annie, who is asking, which type of supplements do you recommend to avoid constipation? So gluconate, sulfate, non-heme, or any other recommendation?
So the supplements usually have a non-heme iron, usually first sulfate, first gluconate. And the type of compound does not make, to my knowledge, the type of compound does not make a difference in terms of constipation, because that is at the very latest stage of the digestion. The compound, and especially if the supplement is coated, has an effect on the other gastrointestinal effects like nausea or heartburn, for example. That has an effect. And the reason for that is because the release of iron is slower, so it's easier to cope with any negative effects. To my knowledge, it's only the iron dose, the one that has an effect on constipation, and then I would say it's 30 milligrams per day. That also is aligned with the requirements. So it should match a little bit the physiology.
Thank you very much. So Annie actually has another question, which is, how do you define anemia in terms of hemoglobin and ferritin levels?
So anemia, and let's see if I can go back to some of the slides. Probably it's here. Sorry, I'm moving. Okay, I don't know if I have it here. So anemia is just measured with hemoglobin concentrations. Ferritin is an indicator of iron stores, so it measures iron deficiency. The combination of both is iron deficiency anemia. So it tells you a little bit of the etiology of anemia. And so for anemia, there is you can go to the WHO website. Actually, for both, for ferritin and for anemia, you can go to the WHO website, the Vitamin and Mineral Nutrition Information System, and you will see a summary of the recommendations. For anemia, at sea level, in pregnancy, is having concentrations lower than 110 milligrams per liter. And that summary also has the adjustments that need to be made as per the altitude. With ferritin, there is actually today in WHO they are discussing exactly the cutoffs for ferritin because there is traditionally has been said that it's 12 nanograms per liter independently of the gestational age. In some cases 15 nanograms per liter, but there is always well, the recent studies have shown that inflammation affects the measurements of ferritin. And inflammation comes, for example, in cases where you have obesity, for example, you have subclinical inflammation. In countries where there is a high endemicity of hookworm infections or other type of infectious diseases such as malaria or even HIV, the body is in a subclinical state of inflammation. So the discussions that are around those cutoffs are what is the right adjustment when you have indication that your body is undergoing inflammation or infection. So there are recommended cutoffs. You can go to the WHO website.
Thank you very much. That was great. So Christy has another question who's asking that Health Canada recommends 16 to 20 milligrams of iron as a part of a multivitamin for pregnant women. So what are your thoughts on the effectiveness of this dose for preventing anemia?
I mean, it's always very tricky to comment on the decisions or the policies of a country. And I personally don't do that. I assume that there is an informed process behind that. Prevention of anemia in Canada, what I could say is in Canada, the challenges at public health are different from those in other countries where these interventions apply the most. Canada is a country with a mild to low prevalence of anemia. So yes, it totally makes sense having a lower dose of iron than in countries where the prevalence of anemia is 40% or higher. So that is my first reaction. I think that whether it's 60 milligrams or 20 milligrams, I'm not sure exactly how they came up to that number, but in terms of having a lower dose, yes, it makes sense. As I mentioned, there is another intervention, for example, which is intermittent iron and folic acid supplementation. The purpose of that recommendation is to target populations where the prevalence of anemia is very low, like 5% or less. And that means that women, most of the women are non-anemic, and what you want is to provide the right dose of iron to prevent anemia. And in that case, I think that is 120 milligrams once a week. If you divide 120 milligrams over 7, you have a very low dose of iron that may be aligned with this recommendation in Canada.
Thank you very much. That's a great response. So Allison has another question. So you mentioned some studies that measured infant iron, so hemoglobin and ferritin. Do you have any results to share for those outcomes? Yeah, all the results are in the systematic review. I must say that it reflects also if you have time, it's a very nice learning experience going through all these 4 systematic reviews. At some point in the previous update, we went from 100 outcomes, because we were collecting everything, to the outcomes that were the minimum essential to make a decision at policy level. If you go to the review, we still kept a lot of the outcomes, and you can have the information. I don't have it with me, but all the data is there, and all the information is there. So I'm happy to comment after that. You have my email if you have any questions about that. I don't have them. We're sharing your email with her. So Martha Lees has another comment and question. So in Northern Europe, iron supplements are not recommended to pregnant women who are not anemic. So how would you screen if they are iron deficient? And do you have any experience on ferritin versus STFR on pregnant women? And if you know where the cutoff on STFR on pregnant women is? So yes, in UK, that's one of the countries. I was mentioning the guideline of intermittent iron and folic acid supplementation. And the other assumption of that intervention, for example, is having a strong health system that actually can screen women. UK is one of those countries where women go to the first antenatal care visit very early, usually around even less than the third month of pregnancy, but particularly those who are middle and high socioeconomic status within the country. So they screen, and my understanding is that the recommendations are screening. They use ferritin as an indicator of iron deficiency, and of course use hemoglobin as a complement to that one. And so what they have is they don't have a preventive dose for anemia, they have a therapeutic dose for anemia. So only if you are iron deficient, you receive iron. What I'm not sure is what is the level of
women that become deficient throughout pregnancy. So, and honestly, I'm not aware of any studies that show that in the UK, for example. So the impact, that's why this intervention in terms of intermittent is, well, there is an indication that you may have, well, that not an indication, there is a good knowledge that you have increased iron requirements. You need a lower dose, you can have it. So I honestly, I am not sure how it changes in the UK because women are not receiving low doses of iron in a preventive way. If the systems are strong and they can screen, by all means, it's important to give iron, and they do it. In terms of the comparison between ferritin and serum transferrin receptors, if you go again to the vitamin and mineral nutrition information system in the WHO website, there is a section there which is called summaries, and it summarizes also the cutoffs for, I think that they have information for serum transferrin receptors as well, probably it's along with ferritin. I do not recall the particular cutoff. I know it's usually at population level in terms of iron deficiency, it's a combination of both. And I don't think that there is a special adjustment for pregnant women.
Thank you very much. So we have another question from Annie who's asking, if ferritin levels are dropping in pregnancy, but hemoglobin is okay, do you supplement? And if so, how much?
So, well, that is a very tricky question. That goes into the clinical level. I would say, what is your starting point? For example, when ferritin levels go down, ferritin is a protein that reflects two things: iron stores, and it's also an inflammation protein. That's why it responds and is affected. The readings are affected so much with inflammation status. So, if you, let's say, if you start at 100, let me start again. If you have very low levels of ferritin, that is the latest status. When you have very low levels of ferritin, is the latest status of iron of deficiency. So usually, what happens is that women may be have normal hemoglobin levels, but iron stores are going down. When you have iron deficiency, so because we are using our storage, and the anemia and the hemoglobin concentrations remain there, so iron is released to keep the production of hemoglobin okay. But there is a point where you don't have enough iron stores, and then it's when hemoglobin goes down, and then you have iron deficiency anemia. In terms of how to interpret the data of ferritin whenever it goes down, as I said, it depends on the baseline value. Because if you have concentrations of ferritin around 80 and they go down from 80 to 60, there is no physiological problem with that. I mean, you might increase the dietary sources of iron, and a woman can be okay, or they can, if they are living in a country where the recommendation is low, having a low dose of iron, that would be fine. They may have a preventive dose of iron, and they may be okay. The problem is for those women that start with very low iron stores and the ferritin levels go down. Let's say, as I said, the cutoff for ferritin is 12 nanograms per liter. If a woman starts with 15 and it goes to 12, then we have a serious problem. So it's very difficult to say what is the interpretation at a public health level, but at clinical level, it depends on the baseline value.
Thank you very much for your response. That's great, very thorough for us. So I'm not seeing too many more questions. So with that, I will carry on with the presentation, but I invite everyone to continue posting questions or comments in the chat or Q&A section. So I'll bring us back to the model of evidence-informed decision-making. And Luz Maria has certainly brought to light the purple research section of this diagram. and what's currently been shown to work in the effectiveness of iron supplementation during pregnancy. So we invite a reminder too that these circles may change depending on the decision that you're making, and the research and your expertise along with community health issues, the local context, public health resources, and community and political preferences and actions will also weigh into your decisions about iron supplementation. Okay, so I'll post up a slide here that we have inviting our attendees today to, for recruitment in our study, supporting awareness and uptake of cancer prevention knowledge in practice. So this is a CIHR-funded study, and we're recruiting Canadian public health professionals to receive concise, actionable messages based on high-quality systematic review evidence. So we'll be disseminating information through weekly Twitter posts, monthly tailored emails, and webinars, much like the ones you've attended today. So I'll remind you that recruitment is closing for the study on March 25th. So I'll put up a call to action slide of what you can do now. So we invite you to visit the health evidence website, where we have a free repository of 4,400 quality rated systematic reviews that are related to the effectiveness of public health interventions. We invite you to register to receive monthly tailored emails of updates to our registry, and also our monthly newsletter to keep you up to date on public health news and upcoming events, much like the webinars you've attended today. We invite you to tell your colleagues about health evidence and follow us on @healthevidence on Twitter, where you can receive daily public health related review tweets, as well as watch for announcements for upcoming webinars. We encourage your organization to use health evidence, and we invite you to contact us if you have any feedback or suggestions of reviews that you would like to see featured in an upcoming webinar session. So I don't see any more questions posted for now. As Luz Maria mentioned, we can send her questions to her email after the session. And the audio recording and slides will be posted on our website, and the links will be posted in the chat section. So I'll leave it to you, Luz Maria, if you have any final comments that you would like to make.
No, just thank you, and thank you everyone for staying until now.
Thank you very much. We very much appreciate you presenting the findings of your review, and everyone for posting great questions throughout the session. We thank you very much for joining us today, and have a great afternoon. So Luz Maria will likely remain on the line here, but thanks everyone.